Hi, we're looking forward to having our webinar today, and we'll get started as soon as people begin to, as soon as others log on. Just give us a couple minutes. So welcome everyone. I see a lot of people are signing on to this webinar, let's just give it another couple minutes to let people continue to sign on. So for those just joining, just give us another minute and we will go ahead and get started. Alice, I think we'll go ahead and get started. Hello, everyone, and welcome to today's webinar, Changes to Privacy Policies and Regulations in the Face of the Coronavirus Pandemic. Really want to welcome everyone and appreciate your taking the time today to listen to this really important webinar that we're holding with Alice Leiter, who is our EHI's Vice President and Senior Counsel, as well as Julie Barnes, who's the founder and principal at Maverick Health Policy. So here are these two very attractive speakers that you're going to be listening to today. And before we get started, just a few housekeeping tips. All the participants are muted. To ask a question, please go to the Q&A box. You'll also see a chat box. This is if you have any technical difficulties. Go to the Q&A to type out your questions, and we will be doing some slides, a discussion, and then we will get to your questions. But you can continue to ask questions throughout the discussion. Just a few notes about eHealth Initiative. We convene executives from every stakeholder group in healthcare to identify and share best practices in the delivery of healthcare using technology and innovations. We have 4 areas of focus with value-based care, interoperability, privacy and security, and analytics. And in value-based care, we're looking at cost transparency. We're looking at FHIR with interoperability, and of course, all of the activities that we're doing in privacy and security with the eHealth Initiative webinars such as this one, as well as the EHI work groups that Alice conducts. We're also looking at the use of social determinants of health. And all these focus areas are really looking right now at how they are applied to our current crisis with the pandemic. You'll find a lot of the information in our EHI Resource Center. We've got lots of white papers, lots of research, and if there's anything that you would like to submit, please go and submit it, and we will take a look and approve it, and would love to have your input. And also the slides are going to be included in the EHI Resource Center. So we're doing a lot of work trying to really provide some information about what's going on in this current pandemic. We've got webinars such as this one. We've also got some webinars coming up on April the 21st. We've got how HIEs are being used to help to exchange data. We've also got one on the 23rd looking at the new, the changes in billing and costs for telehealth services. So please take a look at our website on our event page and register for these events. But I want to turn this over now to Alice, who's going to be leading the discussion with Julie. So Alice, I'm going to turn this over to you.
Great, thank you, Claudia, and welcome everyone. We hope that you are safe and healthy and as sane as is humanly possible these days. I am delighted to be delivering this presentation webinar in the form of a conversation with Julie Barnes. And I wanted to introduce you all to her if you don't know her. She is the founder of Maverick Health Policy, which is a consulting strategic advising firm to organizations, giving them guidance on federal health policies and how they can develop relationships with policymakers and advocacy organizations. Julie is a former policy analyst, healthcare litigator, and Capitol Hill staffer. And she has been incredibly helpful to a lot of the work that EHI has been doing recently in the privacy space, and put together a terrific newsletter through Maverick on some of the privacy.
Hey, excuse me, Alice.
Yes.
Hey, Alice, for some reason, I don't know if it's just me, but your voice is not coming in very clear.
Okay.
I'm not sure if that's the computer or if you can quickly dial in using your phone.
Is everybody finding that? Seems like other people say she's clear. Okay, yeah, so I'm just going to keep talking this way. Sorry, what I was saying is that Julie's Maverick policy newsletter, which I encourage all of you to sign up for, has been terrific. And last week, she put together some wonderful highlights on how privacy policies and regulations have been changing and have been changed in the face of Corona. So with that said, I wanted to give a little bit of background into why we have this webinar and what led to Julie's bringing this all to my attention. Obviously, in the past few weeks, the coronavirus has become the prominent topic for all of us on every front, and it really has turned all of the healthcare privacy debate that we've been having across the country for the past couple of years on its head. As many of you know, Congress has been considering a number of different legislative proposals for probably about 18 months, and they would really supplement HIPAA rather than replace HIPAA with an overarching comprehensive federal data privacy framework. A lot of those efforts have been in response to some of the Facebook and Google quote unquote scandals with respect to data use and collection. And they take a number of different forms, ranging from a fairly narrow to something more widespread like a GDPR for America. But those have all been put on hold recently, obviously. Everything has turned to all COVID all the time. And the privacy discussion that is now occurring is less about what do we need in terms of a new law, but whether or not privacy retains its importance during a public health crisis. So the federal government and a number of state governments have been considering whether we should be allowing surveillance of everyone's daily movements. That's been in the news a lot recently. Something known as contact tracing, tracking who people have had contact with, whether employers should be allowed to take employee temperatures before allowing them to go to work, all sorts of things that might make sense from a public health perspective but raise significant privacy concerns. So knowing also that researchers and public health authorities need to be able to identify and isolate potentially infected patients to get everybody healthy in our society and economy back on its feet, federal agencies have been relaxing privacy rules, just as tech companies are starting to collect more health and personal information to help track this disease and its spread. So that is a lot. And as I said, we've got Julie here, and she's going to talk with me about what's going on, why it's going on, and what the potential downstream implications of all of this are. So we thought it would be helpful to level set before we get into the big changes in federal privacy laws. So let's start, Julie, if you wouldn't mind, by talking about what the current privacy rules are, what HIPAA currently allows during any national public health emergency. Julie, are you there?
Can you hear me now?
Yes, there you are. Hi.
Oh, sorry. Okay, apparently the mute on my computer is somehow attached to my phone. So thank you very much, Alice, for that kind introduction and inviting me here to speak with all of you. I want to begin by just explaining that nothing on this call should be interpreted as legal advice in any way. We're going to be careful about offering educational help, and I am sure there are many experts listening on this phone call who can help contribute to this conversation. We welcome you to do that. We'll have a healthy Q&A in addition to the presentation. So invite you all to join in to the extent that you're able to be helpful as well. So as Alice says, we're just going to start with some basics about how HIPAA has included in its general provisions how patient information can be shared when public health authorities need it as a general rule. Just as a general premise beyond the new privacy waivers that the federal government has made in light of the COVID-19 crisis. So specifically, HIPAA permits covered entities to disclose needed protected health information without individual authorization for several purposes, like to disclose to a public health authority like CDC or the state or local health departments. So an example of that would be when a covered entity may disclose to the CDC, PHI, or protected health information to report all cases of patients exposed to or suspected or confirmed to have the coronavirus. HIPAA also allows disclosures to a patient's family members or relatives, or really anyone someone as a patient identifies that is involved in their care. So a covered entity can share information about a patient as necessary in order to identify and notify family members or anyone else who might be responsible for that patient's care. So an example of that would be when a provider may determine that it's in their best interest for an elderly patient to share relevant information with the patient's adult child. So that's happening a lot lately when family members are worried, and of course we can't all communicate very readily right now. So it's helpful to know that those cases exist during a national emergency, and any national emergency, HIPAA allows and really defers to healthcare providers to determine when to share patient information with anyone, just to prevent serious and imminent threat to the health and safety of a person or the public, including family, friends, caregivers, and law enforcement, and that's without a patient's permission. So that's sort of the general truth about HIPAA in any national emergency, Alice.
Thank you. As a former recovering HIPAA lawyer, I always remember telling people that HIPAA is actually a more deferential law than many might think. And the public health exception for disclosures is a good example of that. So if given that amount of leeway that healthcare providers would already have when it comes to a health emergency or a public health emergency, what has changed recently given coronavirus and COVID-19?
Yeah, and that's the whole reason for this presentation, right? Is we've seen since the onset of the virus and really the crisis that's hit the globe, we've seen so many changes
We'll go over 3 primary HIPAA-related waivers, but I would refer everybody on the phone, and I'm sure a lot of you already know this, but HHS has put out a copious amount of materials and guidance and FAQs, in addition to straight-up notices and rule changes that are HIPAA-related and just privacy-related. Mostly in an attempt to offer reassurance to healthcare providers who are trying hard to just do whatever it takes to get the job done, and they're wanting to obviously avoid HIPAA violations, but I think HHS felt like they needed to put out a couple of just waivers to specifically give that assurance to hospitals in particular. So on March 16th, there was a waiver issued for HIPAA sanctions and penalties that would be considered violations against covered hospitals, including the requirements to get a patient's agreement to speak with a family member or friends involved in patient care. So that's a waiver. There's another waiver of the requirement to honor a request to opt out of the hospital facility directory. Another waiver is the requirement to distribute a notice of privacy practices. Another waiver is the patient's right to request privacy restrictions and the patient's right to request confidential communications. So if a covered hospital fails to do any one of those typical HIPAA requirements, there will be no sanctions or penalties associated with that. That was effective March 15th, and just a couple of days later on March 17th, HHS issued another one. There's
Sorry, Julie, can you ask one thing about the first? Is there a sunset date for that, or an expiration date? Is it, or is sort of like the duration of the crisis?
It is the duration of the crisis, as far as I know. Let's see.
We can look up those dates. I just wondered, these are such, they're of course pushed through quickly to be responsive, and then it always becomes a matter of how actually these waivers are implemented and when they expire, do they expire? So that's something that we can follow up on.
Very much so. So on March 17th, we have another waiver. So, and that was in response to the telehealth services. So while people can't go to the doctor, of course, there's a big effort to allow for greater access via telehealth. And so the Office of Civil Rights exercised its enforcement discretion to refrain from imposing penalties against covered healthcare providers for non-compliance with HIPAA rules in connection with the good faith provision of telehealth services. And that's during the public health emergency that is COVID-19, but the waiver applies to telehealth services provided for any reason, not just for the diagnosis or treatment of healthcare conditions related to COVID. So that notice included that healthcare providers can use really any remote communication product that is available to communicate with patients. And that was a big moment for video conferencing, because usually HIPAA would require a business associate agreement be made with any vendor of telehealth services. But the Office of Civil Rights explained that in this case, you could use things like Apple FaceTime or Facebook Messenger video chat or Google Hangouts, Skype, really anything that wasn't a public platform, just for the purposes of getting services to people that need it, that can't leave their homes. So that enforcement waiver, Alice, does not have an expiration date. So apparently the Office of Civil Rights will issue an additional notice when that enforcement discretion is over. So that'll be interesting to see when that happens. I know there's a big movement among the folks that have long been advocates of telehealth services to try to see how we can extend telehealth services for the newly created demand of them for the duration. It just seems like the time to extend that access for a while.
If that can be
So
a silver lining of COVID, we'll take it.
Right. Okay, so just the third thing I was going to mention about the new privacy waivers is was issued on April 9th. So we've got a March 16th, a March 17th, and an April 9th waiver. And this one is about testing. So as we all know, there's been an incredible effort to get as many lab tests out as possible and in many forms as possible and as many places as possible. And what's been happening is testing sites are sort of popping up all over the place, not the least of which in drive-through sites at major pharmacy chains, for instance. So there's been allowances for those new types of testing sites known as community-based testing sites. Normally, there'd be violations of HIPAA that a normal clinical lab would have long since taken care of, but in these emergency times, there's just no way to avoid some of the sort of non-private scenarios that come with these kinds of drive-by testing sites. So the Office of Civil Rights issued an enforcement discretion of HIPAA for those providers and business associates that are conducting those lab tests at those sites. So there's no violations for whatever they're doing in violation of HIPAA at those sites. And even though it was issued on April 9th, it was effective starting March 13th. It had a retroactive effective date. So all of the ones that popped up in March since March 13th are pretty acceptable depending on what's happening at each of those sites. There's definitely sort of fine print in all of these guidances, so you want to make sure that if these apply to you, you're reading all of those guidances very closely, preferably with your lawyers. But that is all up on the Office of Civil Rights website that help explain not only these three waivers, but just a whole host of FAQs that have come up since the crisis began, including how you share information with first responders.
So in case anybody needs some bedtime reading, we direct you to the HHS and OCR websites for all of those guidance documents. Could you talk a little bit about the CARES Act and the changes that it made to federal law, specifically the Part 2 regulations?
Absolutely. So you probably know the CARES Act is what we're referring to. That means the third economic stimulus bill, the $2.2 trillion economic stimulus bill that became law in late March. It also makes some fundamental and actually permanent changes to the federal law that's sometimes referred to as 42 CFR Part 2. That governs the confidentiality of substance use disorder records. And so this has been a long time conversation that finally sort of came to pass in this last stimulus bill. So after really years of keeping those records separate and at a higher level of privacy protections, healthcare providers now can disclose substance use disorder records. For short, they say SUD. SUD information for routine functions like treating the patient and billing for services, things that healthcare providers are accustomed to doing with other records under HIPAA, but now they're also able to do them with substance use disorder records if they obtain written patient consent before disclosing, which is different from other records under HIPAA where no consent's needed. But the new law adds important new protections for these kinds of records, like you can't discriminate against individuals with substance use disorders in various ways. So you can't discriminate against them relative to healthcare, employment, or rental of housing, that sort of thing. So there's a number of items you can read about this under the SAMHSA website, SAMHSA. That's where the, I think the best guidance is located there. Alice, I think we can probably post the link to the SAMHSA website for people if they need it.
Yes, I'm happy to circulate links to all of these guidance documents or put them up on the website in our resource center with the presentation. And you know, we should have said at the beginning that there's so much going on that this is certainly not an exhaustive list of every single privacy issue and change that has come up. But Julie, are there any other ones you want to highlight that have been tricky, that sort of things that the feds are battling with now?
Well, sure. I mean, we could go on all day about the sort of tricky privacy issues, but there's a couple that are very much worth mentioning. One of them is another lab test situation. So as we all know, you know, thousands of COVID-19 lab tests are being conducted at various hospital labs every day, and the White House Coronavirus Task Force is already in the process of collecting data from public health labs and private lab companies like Quest or LabCorp, but no one has the sort of automatic ability to track that data from hospital in-house labs when they do their in-house lab testing. So on March 29th, Vice President Mike Pence, who leads that White House Coronavirus Task Force, sent a letter to hospitals and asked them to send daily updates on the COVID-19 testing in those in-house laboratories. So it's very new and very, you know, kind of an odd moment in time where we find hospitals reporting via a spreadsheet to HHS the test results daily by 5 p.m. So, and they obviously need to make that de-identified information, but that's sort of an interesting new tricky wicket that hospitals are contending with. Another area that is interesting and a little bit morbid is what hospitals are required to do under HIPAA to limit the use and disclosure of data after a patient passes away. So hospitals are allowed to share data with public health authorities, but there is an enormous amount of state laws that apply that limit how that data might be used. So HIPAA generally requires hospitals protect medical data to the same extent as they would for a living patient. And so a hospital can share, say, the number of COVID-19 deaths that they've suffered, but largely can't share details, right, about a specific patient death with the public or the news media beyond general information. But how those disclosures actually work operationally varies by state law, because there's just a myriad of state public health laws that govern that public health reporting. So the data being collected isn't particularly consistent, which is just one of the things that we're noticing as a result of the pandemic.
It's always, interesting to see how this notion that we talk about in the HIPAA privacy world all the time of the patchwork of state laws and how HIPAA is a floor and then the states can layer on top of it. It's always interesting to see real world examples of how that plays out, and it doesn't always come up in the context of public health, but I've found that really interesting, even watching the interaction between the state and federal governments on any policy toward COVID-19 and how we're all being asked to behave. This is a really good example of how this can make for headaches when it comes to new requirements. Well, one of the things that we thought of when we were brainstorming this presentation, and as I've been thinking about this, and Julie, I know you have too, is that it's all well and good to do all of these amazing responsive things to try to combat a crisis and get everybody healthy, but there are always going to be downstream implications of those. And I was hoping you could talk about some of the other things that are happening outside the federal government, and then we could talk a little bit about some of the risks that those may raise down the line.
Well, sure. And this is, one of the more interesting things that's going on really in our collective conversation, right, is that we've got a whole new weird and kind of terrible realm of how we cannot go to work and we cannot go to school and we cannot go to parks, and how we relieve ourselves of these terrible times is really dependent on how we are monitoring and tracking our not only the virus and who has it, but who has been exposed. And so as a result of those kinds of conversations about surveillance, it's sort of ignited this conversation about what's more important, reopening the economy or our individual privacy, especially as it relates to our healthcare information. And so there is this dynamic going on at the highest levels of both the federal and state governments, but also local communities who are trying to figure out exactly how to accomplish this. And so this digital surveillance, or sometimes called contact tracing, is just the means by which you can track and isolate contacts in order to reduce the spread of the virus. And it would show, these tools, these apps would show a person's contacts and whether a contact tested positive for the virus, and then how you go about containing that spread. And we've seen other countries do this with some success, and we've seen, I think, the European Union so far struggle with how to make this happen with GDPR in place. And now we are about to struggle with the same conversation, and really are already, because the Trump administration officials who are working with Jared Kushner on the coronavirus response officially asked health technology companies about creating a national system that could track some of these metrics that are going to help us combat the coronavirus. And that proposed network would draw on just a vast amount of patient data. And the object of the game is to give officials near real-time updates in the hopes that we'd be able to figure out which parts of the country or which parts of the community even are safe and can, sort of relax social distancing, get people back to work, and who really needs to continue to stay home. So it would mean just a significant expansion, really, of government use of patient information. And we're going to have this whole new dialogue about what that means for privacy. And I just want to say, before we sort of talk about who's saying what about what, not only are the folks in the Trump administration just sort of collaborating with the private sector about how to make this happen, there are former credible, I'd say bipartisan, healthcare experts, former top government officials like Scott Gottlieb and Mark McClellan and Farzad Mostashari, who have put out a white paper about just how to make this happen, so that you can figure out how to go from, basically a universal quarantine to sort of a case-by-case regional situation. So it's got some serious momentum. And I think people on the phone have probably seen the national reports about Apple and Google announcing their cooperation on a contact tracing system, and how you could basically allow tracing by local governments. And then there's a conversation about how you opt in to those. So, other than that, there's MIT has got a contact tracing apps project that apparently 3 local governments are expected to sign on the dotted line about. Facebook has got access allowances for researchers to look at mobility patterns. It's supposedly anonymous, but again, that's a question. So we've got a lot of activity. I mean, that is a very, very small snapshot of what's happening out there. But basically, everyone is trying to figure out how to do this in a way that doesn't squash civil rights, but that keeps us all safe.
Right. I mean, that it's so interesting because we want to throw everything we possibly can at this problem, and our technology companies are in some way our greatest asset. But we also know that technology companies and their collection and use of data is constantly raising widespread privacy concerns and fears. And not only that, but some sort of ethical and societal concerns over how do we want to live and how do we want to protect our autonomy and our privacy. So has there been discussion at the same time that these initiatives have been proposed and the excitement has been mounting about some possible ways to return our life to somewhat more normal? Is there discussion publicly about the ethical and privacy concerns that these efforts may involve?
Indeed, we've got at least a couple of senators and one House representative who have been active on these issues in the past, but have absolutely sent a letter to the Trump administration just expressing concern that this sort of massive health data collection is wrought with issues. I'm trying to be careful about how I say everything, because it is not at all clear that something like this won't happen. And I think these, like Senator Mark Warner, who has been involved in this conversation for years and actually has a professional background in healthcare technology, is really, I think, legitimately concerned, but also is at the top of the list of people who understand why this might be what we need to do, have this sort of modern response to what is a very difficult to track problem. So yes, they wrote a letter expressing concerns and basically explaining what their concerns are so that there can be some sort of dialogue about it. And then last week, the Senate Commerce Committee held what's called a paper hearing, which just means they didn't have any witnesses because everybody is supposed to be staying at home. But they had a hearing on big data and the coronavirus, and basically tried to figure out how to recreate the conversation that was happening just a couple months ago about a federal privacy law and how it might apply to what's happening now. So there is sort of significant conversations going on about exactly what to do, but this could not be a more fluid situation. It could not be at more sort of levels of government with all the disparate political philosophies we have going on. There's definitely lawsuits happening against governors for keeping the stay-at-home orders in place to what people think is an overwrought situation. And then there's the opposite, where people don't think enough is being done to protect everyone. And so you insert this sort of long time and ongoing conversation that we always have in this country about individual healthcare privacy. It is going to be really difficult to come up with solutions for this particular problem.
Well, I'm glad that you're in charge and you can figure this all out for us. There's always, in the discussions about the need for a comprehensive federal data privacy law, there are always discussions about to what extent is there even such a thing anymore of just health data, or as opposed to sort of consumer data or personal data. And this is such a clear example of how everything can become health data. Certainly GPS monitoring of people's movements right now has a health application and a health context, and we often parse out those different data types. But It just adds to the complexity of how, but not only how urgent it is, the momentum had been building. I think the momentum has crashed upon all of us to have some federal action for this. And I understand the feds are doing the best they can now, but these little waivers and they're just stopgaps. As we talked about earlier, there aren't even clear timelines for what will happen when the crisis passes. So I urge all of you to stay involved in the push for and advocacy for new legislation on this front. I have gotten a number of different questions in the Q&A box, which I'm going to go through as applicable. And if you haven't asked a question, you have one, please type it into the Q&A box. I want to reiterate what Julie said at the beginning of this, which is that even though we have these really fancy JD letters after our names here, nothing that we're saying here should be taken as legal advice. And some of these questions that I have are fairly specific to HIPAA. So Julie and I will do our best to answer them without the privacy rule in front of us. But please don't have any of our sort of gut takes on these questions constitute an official yes or no on some of these questions. And there are a number of them backing up to the HIPAA privacy rule and what's allowed with respect to a disclosure without authorization for public health purposes. A number of people have asked whether or not an employer can be told about an employee being positive for the coronavirus under this public health exception. I can dig back into the recesses of my mind, but Julie, do you have an answer to that? Okay, she might be on mute. We will, let me read a couple of the others. And Julie, if there's one that jumps out at you that are you there?
Yeah, I am. I'm so sorry. I don't know why the computer is controlling my phone mute button, but it most certainly is. So yes, I was basically applauding the number of law firms that have in just the last couple of weeks posted, either a reposting of what has been a long time set of guidance FAQs on official websites for employers, but also just kind of refreshing some of those for purposes of COVID-19. I think it's an excellent time to be asking the questions about employers who are non-covered entities under HIPAA. If an employer is a covered entity under HIPAA, that's a whole different sort of bucket. And again, it falls under the HIPAA guidance for professionals on the OCR website, but and just HHS website. There's a number of different things. But if everyone is even able to Google employer and then HIPAA and then COVID-19, you'll see an extraordinary number of law firms who have helped with just this issue, what employers need to know about HIPAA under COVID-19 sort of time frame. So, as the bottom truth is sort of like level set, HIPAA applies to covered entities. And if you're a non-covered entity, so not a health plan, not a healthcare provider, not a healthcare clearinghouse, then you are not covered by HIPAA. So if you just start from there, it really moves more along the lines of Americans with Disabilities Act and sort of regular employment non-discrimination rules about what you're able to disclose. Now, in a public health emergency, everything changes. But really, some of those basic data privacy considerations for employers are still pretty standard.
That's a great point about the law firm FAQ documents. Hogan Lovells has a great healthcare practice. Epstein Becker has one too. We can find some of those and put them up on our resource center too, if it would be helpful to put along with these slides.
Yeah, the bottom line I would say, Alice, is that employers really just need to be sharing a minimal amount of personal information. If they find themselves in a position to share. But it's really about making sure that they have consent, and there's, with all of these things, it's always really about common sense. And again, because regular sort of employers, not non-covered entity employers, are essentially just companies trying to do the right thing by their employees. The bottom line question is, can you share? Do you have permission to share? And are you only sharing what you need to share with who you need to share it? So that's sort of the sort of bottom line. I think where it becomes more complicated, and what we're going to see if we get more into the surveillance time, is what are employers allowed to do because they're kind of going to be on the front lines of the public health crisis. And so part of what was in the Gottlieb, McClellan, Oshashari white paper from Duke was this conversation about whether or not, temperature taking and sort of clearing people with lab test results are going to be part and parcel of an employment scenario in order to let people back into a workplace. So I don't think we really have the answers to those kinds of questions right now, because there might be, new rules pending, whatever the decision making is at the sort of government and local levels about that.
Yeah, I would reiterate what you said earlier. The concept in HIPAA of the minimum necessary is really controlling here. That even though some disclosures that might not otherwise usually be permitted might be now, it's always kept to the minimum amount of information necessary, and that has been specifically stated in some of the guidance that's been put out recently from OCR. I see a question here about, have we heard anything about HIPAA's minimum necessary standard needing to be waived for organizations that are sending information to the government? I have not, actually, quite the opposite. Julie, have you heard anything different than that?
No, I would actually say, I think all of the guidance has been really clear that minimum necessary still applies in almost every case, which makes total sense. You don't have to overshare. You have to share what you have to share. And I think really all of the guidance says something like that in some way.
Right. Yep. Let's see. Here's a question that asks how verbal consent works if a doctor is doing a video visit, like a FaceTime telehealth visit for a patient that's in the hospital who might not necessarily be conscious. My guess is that the healthcare power of attorneys or healthcare representatives step into that role the same way they do even when it's not in a crisis. But I don't know specifically if there's something in telehealth that says anything different than just under regular HIPAA rules.
There is definitely something, I'm trying to find it, in one of the guidance documents about, maybe it's in the bulletin that was issued in March, about, because this is unfortunately, very unfortunately, come up where you have, people on ventilators and people who are very, very sick in the ICU and unconscious, and they cannot speak. And so there has been, I'm not putting my finger right on it, but in the event that patients are not able to provide permission, there is a general sense about healthcare providers' discretion to tell whoever they need to tell. And even there's been, narratives on the news about how, healthcare providers held up a phone so a patient could kind of, say goodbye before they were going to lose consciousness. But I can't put my finger on it just a second. But it's 45 CFR 164 something. I just don't know, 164.5 something, and I just can't put my finger on it. If somebody out there knows the site, I welcome you to share with the group.
We can dig it up in our guidance links that we'll post. Here's a question about Alphabet Company, SADA's announcement that they're going to be providing a platform for hospitals to share information about beds, vents, test results, etc., which the hospital community has embraced. SADA is requesting that any provider interested sign a data use agreement that allows them to use the data for public health. I cannot speak to this. Julie, do you have any thoughts about this and what that might mean?
This is on the Q&A. I'm not seeing what you're seeing.
Yeah, it's about 4 from the bottom from Brett Meeks.
Oh, okay. Oh, yeah, okay. For hospitals to share. Oh, yeah, right. No, that's right. There's all kinds of these sort of bed and supply tracking apps right now. Requesting any provider interested in signing a data use agreement. Well, so the question is, I mean, do you have any thoughts? Sure, we have thoughts. We, I think, are going to be seeing a lot of this, and again, more so when we try to coalesce around a maybe national, maybe not quite national surveillance program that involves the data about tracking all these things, not the least of which for FEMA's purposes, so we can get the emergency supplies to where they're going. You know, this strikes me as a private B2B contract, and so this just kind of speaks to a larger issue, which is we are the United States of America, and we're not Poland or Taiwan or Singapore, and we do not have a single source of, well, anything, but certainly not for healthcare purposes. And so we don't have one singular source of data. We don't have a singular source of reimbursement. We don't have a singular source of mandate or requirement for any kind of universal healthcare system. And as a result, we have private companies popping up like this that might be doing the public a great service in tracking what they're tracking. And of course, there's news media organizations like the Atlantic and the New York Times, and there are academic institutions like Johns Hopkins and MIT that are doing similar kinds of work. And the question is, you know, how do we govern it, and how do we sort of create a credible situation when we have so many different attempts to track disparate levels of data? And I'm not sure I have, you know, a great answer. That, I mean, I again would refer to the white paper of the experts of old about how to do this right. Whether or not, you know, Alphabet and HCA have the right to do this, I think they do, but it's a question for, really, I think in this particular case, the CDC and FEMA and what they need to know. I know they've put out requests for this kind of information, and I don't know if this one falls under it. I think they've only blessed two trackers of this information right now, but you know, at the moment, so long as actors are good actors, I'm not sure why we would slow down really any source of information that we all need to be sharing with each other right now.
That's a good segue into another question that touches on this patchwork of state law issues we talked about earlier. This question is, given that OCR has issued these waivers and enforcement discretions, how does it play out with state healthcare data privacy laws? HIPAA is the floor, and it is true that states can have more stringent requirements. So what happens with the state's authorities and the state's enforcement when the HIPAA floor is lowered, and how are covered entities and business associates navigating this? That's why there are healthcare lawyers in business these days, because those are really complicated issues. I don't know that there's a quick answer to how everybody's navigating it, but my assumption would be that right now everybody's trying to get on the same page. But I can't speak to any specific state government and whether they've come out to say that they're going to honor this lowered floor or relax their own requirements to the extent that they differ. Julie, anything to add to that?
I feel like I see states saying different things every day. It's really hard to keep track. I think they're trying hard to keep up with their own fluid situations, and I know that they're all exploring different solutions. But I don't think it would be fair to try to assess a blanket truth to anybody right now.
Right. A couple of questions about the relaxed telehealth enforcement and whether or not that's going to be extended indefinitely. We talked about that a little bit earlier, that there have been calls for a long time to have some of the changes that have been made now in place before there was this crisis. And given that we don't have an official expiration date on when some of these provisions will sunset or if they will sunset, I think that's an open question.
Look, it's definitely an open question. I think, commercial payers have been making telehealth visits available for years, and there's obviously standalone operating telehealth services not associated with health plan that have been offering services direct to consumer, and there's just been very little relatively little utilization up to this point. And now, of course, we're seeing an explosion due to necessity. And so I think the interesting question with post-COVID-19 telehealth service availability is really a couple of different parts. One is, will the demand continue? I mean, I don't think it could continue at this pace because, of course, things will open back up and people will naturally go back for visits that feel like they need to be in an institutional setting. And yet I think this has made a demand very real and very probable because both providers and patients realize how convenient and how good it can be. The other question, of course, is reimbursement. And at the moment, telehealth services are being paid in a way that I don't think they would normally be paid outside of a public health epidemic that caused, such a change in the healthcare in-person scenario. So we've got a sort of a utilization question, demand question, reimbursement question. Also have a, what does this quality really look like of in-person visits, and how do we quantify that moving forward? So this has also been a conversation forever, and there frankly hasn't been a lot of studies. There have been some, but there needs to be a lot more research and analysis of data of how this has gone for people, and if it was successful, if people are happy with it, if providers are happy with it, what happens when you add diagnostic tools that people are using at home, what level of care can be fairly rendered by video conference, and beyond that, there's a question of what if it's not by video? What if it's a call? What if it's an email? What if it's virtual in some way, but not by video? So I think there's a number of questions that are left unanswered by whether or not telehealth services can continue post COVID-19 pandemic crisis are myriad and really require some thinking and some new advocacy based on what's happened here. It's really changed the dynamic, and I think for the good. But there's a lot of things left open to how this could work moving forward in a more normal time.
We'll just have this webinar, every 6 weeks from now until it's ready to keep everybody updated.
Right.
We have time for a couple more. Here's one I do not know the answer to, but Julie, maybe you do. Do you know about the specific rules governing recording of telehealth visits, like a Zoom visit or a cell phone or other? Is Has the recording of visits been specifically addressed either by the states or feds?
I'm just going to say I don't know, mostly because I don't know what's happened lately. So can we get back to that questioner?
Yes, and hopefully all of you will have, at the very least, my contact information, and I'm happy to answer questions later. If you want to email me, I can pass them on to Julie as well. Some of these we would have to look into a little bit. Same thing that I don't know the answer to. It might take some thinking or research, but how organizations are handling operationalizing 1135 HIPAA privacy waivers with respect to the 72-hour requirement upon implementation of a hospital's disaster protocol, given that that's such a small window of time. I don't know. So we can certainly ask our provider colleagues about that. I am looking through.
Oh yeah, okay, I'm seeing that now. That is part of a guidance document, but that is, I mean, yeah, what we should, I mean, that is almost a survey question, because I think it depends, right, on the organization that's implementing that requirement.
I think we've hit most of these others where whether on a high level generally or more specifically. But again, if we didn't get to your question and there's something else that you want to ask or have answered, please feel free to email us at EHI directly. And I am delighted with this conversation and so happy that Julie was able to join us, and we had such a wonderful group of questions and participants. So thank you all for joining us. And again, I do think that this will be an ongoing, certainly an ongoing process, ongoing issues, and I hope that you all will join us for an ongoing series of discussions about these both interesting and sort of uncertain issues. So again, Julie, thank you. Thanks all of you for joining us, and we hope to talk to you all soon.
Thank you, Alice.
Bye.
Bye.